This sagittal section shows the relationship of the inferior turbinate, middle turbinate, and the superior turbinate in the nasal fossa. The sphenoid sinus is readily identified. Some structures are seen better in this coronal view, where we are able to identify the maxillary sinus ostium coming from the maxillary sinus itself. The ostium of the nasal frontal duct also opens under the middle turbinate. We see the ethmoid sinuses and the location of a properly placed antral window. Now, if we take the superior turbinate out, as well as the middle turbinate, we can see where the anterior and the posterior ethmoids are located. We can also see the relationship of the sphenoid sinus and the frontal sinus. The point I want to make here is that 90% of the polyps that are going to be identified in the nose are going to come from the anterior and the posterior ethmoid sinuses. Now, in this drawing, we have surgically removed the superior, middle, and inferior turbinates and can identify the nasolacrimal duct as the only opening in the inferior meatus. The frontal sinus ostium, the anterior ethmoid ostium, and the maxillary sinus ostium open under the middle turbinate, and the posterior ethmoid ostium will be found under the superior turbinate. The sphenoid ostium will be located medial and superior to the superior turbinate. There are only 6 ostium to deal with, and although we see some polyps coming from the ethmoid and on rare occasion from the maxillary ostium, 90% will come from the anterior and the posterior ethmoid sinuses. Now, in this view, we are looking down on what is a straight nasal septum. In reality, it is rarely straight. This can complicate trying to differentiate protrusions into the nose, including polyps. Please pay close attention to the proximity of these air cells to very important structures, particularly the eye. Notice the sphenoid sinus posteriorly is segmented into 2 separate sinuses. This is normally the case. Keep in mind there are 2 levels, perhaps even 3 levels of ethmoid sinuses, and there can be anywhere from 3 to 18 ethmoid sinuses on either side of the nose. Now, you might conceive of the ethmoid sinuses as a trapezoidal box. This box is filled with tennis balls that are only a few millimeters in diameter, and from them are coming the polyps that result from inflammation. This inflammation is a result of obstruction, stasis that follows allergic reactions, bacterial infections, and anatomical occlusions. Now, if we look at this from another point of view, we can conceive of these very small ethmoid sinuses with tiny ostia and an increasing swelling of the mucous membrane. This swelling of the membrane continues to expand to a point where it becomes necessary for it to exit the sinus itself. It does so by forming a stalk. You can see the stalk here and the polypoidal extension that results, which can become huge. It can occupy large areas of the nasal fossa. This kind of obstruction will only be temporarily relieved by surgically excising the polyp at the ostium, because as you can see here, this will not solve the infection in the sinus itself. The polyp will tend to regrow. Now let's take a look at this by passing the fiber optoscope over the inferior turbinate and examining the middle turbinate and the middle meatus. We will see polyps coming from the anterior ethmoid sinuses. Now you want to keep that so that I don't have the weight of it. Thank you. Now, in this particular instance, we're looking at a middle turbinate and a large structure which comes down and seems to coalesce with the mucosa of the septum, and this could be a syncytia, but it is not. It's a turns out to be a fairly easily to demonstrate polyp. You can see how you can insinuate the polyp away from the septum. Then you look up above here and you can see that the middle turbinate itself gives a little bit. There is some polypoidal nature to this. It is somewhat swollen, but that's definitely the turbinate. And then, okay, you all right? The anesthesia that's used here does not prevent sneezing, and you will see that as a problem associated with manipulation of the mucosa. Now we're looking at a different kind of polyp. Notice the vascularity that you can actually make out here. Again, this is from the middle meatus. As we watch this polyp, you'll notice the consistency of the tissue is really very different from the mucosa that surrounds it. Okay. This is a typical polypoidal extension from the middle meatus. Yeah, just breathe real quiet. Come up over the inferior turbinate and proceed posteriorly, and you come upon a middle turbinate that in fact has 3 distinct lobulations associated with it. This patient has a bolus turbinate on the left side of the nose. This is, of course, the right. That's a polyp. Looks just like a bifid turbinate, but it's a polyp. See how well you can move it? It's a rather large one. Now, I want to get underneath this thing. See about this. Okay, cannot move. There it goes. It's also a polyp. This structure here is polypoidal turbinate as well. That's a polyp. Those are polyps coming off of the turbinate. That's very interesting. So far we've been talking about polyps that are coming from the anterior ethmoid sinuses only. Now I'd like to talk about polyps that are coming from the posterior ethmoid ostium. This is a little more difficult to get at, but if we take the fibroscope and place it on the floor of the nose, we ought to be able to direct it superiorly along the face of the sphenoid bone. But what we're going to encounter are polyps which will prevent us from being able to see the sphenoethmoidal recess. Now we have the scope on the floor of the nose with the inferior turbinate on the right, septum on the left, and we're looking through the choanum. We'll direct the scope superiorly. Okay, turn the light down, please. Okay, he's got something on this side which is preventing me from getting up there, and that's going to be a polyp right there. See it?
Right there?
Yeah, he's got another one sitting lateral to it. See the small one right here? Okay, and this is a big one. Well, he knows he's got those polyps, and they're under there's another one.
Yeah.
Sitting control. Okay. He's got some little guys over here on the side, so he's got a great patch back there. Okay, and you can see them very nicely right here. Got a bleed point sitting here. Do you get a little blood in your mucus from your nose periodically?
Mm-hmm.
That's another polyp sitting right there. Another one here.
That could be from the steroid spray.
Uh-huh. We're looking at the inferior turbinate on the left, and there's a lobulation of the inferior turbinate, which is frequently seen with inflammation. The floor of the nose is well visualized, and you see some venous patterns. All of that's normal. And sliding along the septum, looking superiorly, run into what has to be a polyp, another polyp, and very likely from the anterior ethmoids, as a matter of fact, because that's the middle turbinate, and what we've... No, I'm sorry. They're from the posterior ethmoids, because this is the middle turbinate right here at 3 o'clock, and these are definitely medial towards the septum. And you see a string of them. And their stalks will lead us all the way back to the posterior ethmoids underneath the superior turbinate. Light down, please. You get some reflection, but it's fairly easy to see. Again, the orientation is floor of the nose, inferior turbinate, posterior margin. The coena light up can be seen with a little more light in the at the rear of the nose with the adenoidal pad, and then the polyps become very apparent, light down, and you see them cascading from the superior turbinate, and the superior turbinate is approximately in the middle of the screen here. Now I want to show you something that I think is a bit unusual. It's an example of a polyp that emanates from the posterior ethmoid sinus. It will transit through the coena of the nose and will occupy an enormous portion of the nasal pharynx. Now the reason this is so important is that this patient had an allergy evaluation, was on dust treatments, got rid of her dog, and we're going to find out that her unilateral obstruction of the nose is not due to allergy per se. Now here's how the examination went. We're in the right side of the nose. There's the floor of the nose, and we have the inferior turbinate, and right on the lateral portion of the inferior turbinate between it and septum there is a tissue structure which is obstructing the nose over here on the right. Turning the scope immediately above that, you can see the inferior surface of the middle turbinate, and it would appear that this object has its origin superior and posterior to the middle turbinate, and certainly medially. Most likely, okay. Now, assuming that that's not adenoidal tissue, which I don't think it is, and assuming that it's some sort of a polypoidal structure which is sitting in the vault, it certainly could account for disproportionate obstruction in the right side of the nose as compared to the left, which is your history, is it not?
What now?
The right side of your nose is where you have the problem.
Yes.
Well, this is sort of like somebody put a plane there. All right? Now, I want you to talk for me. Say yes, yes.
Yes, yes.
That's going to be a polyp. It couldn't move any other way like that. Now I want you to breathe in through, I'm going to hold this left side of your nose so that you're breathing through the side that I'm looking at. And I want you to suck air in gently first. Close your mouth and suck air in gently. Now blow it out if you can through that area. Okay, you're doing just fine. You did exactly what I wanted you to do. Now just stop and take a nice breath so you don't die of air starvation. I think you're having an explanation here of why your wife is obstructed, and this is the reason. Okay, now I want you to take a breath in now. Now out again. Try to blow through that nose. Okay. She has a ball valve polypoidal structure which is obstructing the nose, and if that wasn't there, I think she would breathe a lot better. Now let's look at this from the left side of the nose. Superior turbinate looks nice and normal. Middle turbinate looks okay. She does have some deviation of the septum into this side of the nose. As we go posteriorly, she allows us pretty nice access all the way into the posterior pharynx. But as you approach the posterior pharynx, I'll be darned. Now this polyp has extended itself almost over to the orifice of the tympanopharyngeal duct. You can see how as she swallows there, it comes in contact with the orifice. It is beginning to extend into the coena on the left side of the nose, and could be anticipated over time will obstruct the entire nasal pharynx. Now, the thing that's crucially important about this is the irregular edges of this polypoidal structure. One could not tell for sure that this was not an involuted polyp, and also in the differential would be a carcinoma. As it turns out, surgical removal of this polyp identified it as a single polyp that had to be cut into 3 different segments in order to be removed. It had extended into the right coena, was in contact with the middle turbinate approximately 20 to 25% into the nasal vault, and was effectively obstructing it, as we saw on the right side of the nose. It seems to me that this is a classic example of why it's so important to look in the recessed areas of the nose that cannot be examined by routine procedures. Now I'd like to introduce you to some polyps that are not coming from the ethmoid sinuses or from any of the sinuses. They are coming as direct extensions from the mucosa of the structures of the nose. In this case, we're looking at what appears to be a polyp in the floor of the nose, and it is a direct extension of the inferior turbinate and coming from its inferior surface. Now we're going to take the Q-tip here and see if we can manipulate this polyp in order to demonstrate that it is a polyp and not something like a rhinolith or a bony extension of the inferior turbinate. I think you can see here that this polyp does move rather readily, and I think you can see that it is a direct extension of that turbinate. Now with the fibroscope lying on the floor of the nose, we're going to direct it superiorly and at the inferior surface of the middle turbinate. We'll be starting at the posterior margin of the turbinate and proceeding anteriorly. I think you can appreciate as we proceed forward the changes in the inferior surface of this turbinate. You have remarkable degeneration of a polypoidal nature. We can also appreciate on this examination the ostium of the maxillary sinus. Now we're going to direct the scope at the superior turbinate and look for polypoidal change on that turbinate. Proceeding from the floor of the nose, we come up to the superior turbinate and you see a cystic change on the turbinate itself. It's actually hemorrhagic. At approximately 11 o'clock, you can see the ostium of the posterior sphenoid sinus. Now, to give you an idea of just how far this polypoidal degeneration can progress, we'll take a look at this 14-year-old youngster, and starting in the nasal pharynx and proceeding anterior now, we're looking at the septum on the right, the inferior surface of the middle turbinate superiorly, and the inferior turbinate is at approximately 7 o'clock. And you'll notice this massive degeneration of the entire mucosa of the nose. This youngster has had rather extreme allergic rhinitis, has used some topical medications in the nose, has used some topical cortisones and ephedrins, but there is no indication that this has been to abuse. You'll notice that this degeneration in the mucosa extends almost to the anterior portion of the inferior turbinate. One could be quite misled on anterior examination here, as you would not appreciate anything other than the rather massive obstruction that is seen in the anterior 1/3 of the nose. Now let's go back to the graphic that shows us the relationship between the ethmoid sinuses and the other structures in the middle of the head. Keep in mind, these ethmoid air cells proceed posteriorly in a linear fashion. As we graphically represented them here, they consist of small enclosures in which the mucosa has become redundant. Now, recalling the trapezoidal shape of the ethmoid sinuses as they assume a relationship on either side of the nose, and if we can conceptualize these spatial relationships, we are in a position to discuss the surgical interventions of the anterior and posterior ethmoidectomies often carried out by otolaryngologists. We want to show you how this would look through the fibroscope. As we proceed posteriorly along the floor of the nose, about mid inferior turbinate, and direct the scope superiorly, immediately see that the architecture is completely different from the normal anatomy, period. There is no middle turbinate, and in fact there is only a residual superior turbinate, which is not well visualized. What we're looking at here are the posterior ethmoid sinuses, which have been marsupialized, and you can see the multiple nature of these sinuses, 3 being immediately identified here, with a 4th superior and then a 5th. Light down, please. Close inspection of this area allows one to see the depth of these air cells and the contiguous nature of them. The attempt here was to get better drainage and aeration with this procedure. Now, by turning the scope towards the septum and directing it superiorly, one is again confronted by these cavernous sinuses. In this point, we're looking into a exteriorized sphenoid sinus, with only part of that sinus being visualized. For orientation, as we proceed into the floor of the nose again, you can see the choana and this small lobulation, which is immediately lateral to the choana. And then as we decrease the light and proceed superiorly, you can see immediately the excavation that has taken place here. The structure in the center of the picture now is the remnant of the superior turbinate, poorly seen as we get a little mucus material on the tip of the scope here. And we encounter this firm ridge, which is not mucus, but is an epithelial bridge. Did I hurt you doing that? Okay, which is firm and remains in place even when it's encountered by the scope. There's a small bleed point on the superior portion of that bridge. The use of the fiber optoscope in examining the nasal airway is a remarkable advancement for the clinician. It certainly has changed our perspective for recognizing pathology in the nose and for being able to associate patient complaints with specific pathology on exam.